We've looked at the aorta and things that can go wrong with that, so we're going to continue our vascular tour, looking at diseases of the peripheral arteries. And then we'll finish up with the specific beds, renal and carotid, to end today's festivities. So we'll go through these first couple of questions again. Question number 1. Using the information provided, what is the correct ankle brachial index for the right leg? I'll give you choices in a second, but I'll let you jot down the numbers you think are relevant. If you get something greater than 10, you're wrong. So is it 0.73, 0.76, or 0.8 is what you're going for here? All right. Question number 2. A 75-year-old man with a history of AFib, not on anticoagulation, presents with an acute right foot discomfort over the last 3 days. On exam, he's got a pale, cool right foot with inaudible Doppler for distal pulses. He has intact strength. We have some squiggly lines. What is the most appropriate treatment strategy for revascularization? Is it systemic lytics, 48 hours of IV heparin alone, catheter-based lytic plus or minus a mechanical device, or surgery? Okay. We can be certain that the majority of you didn't get it right, apparently. Question number 3. A 67-year-old man with a history of tobacco use and hyperlipidemia is found to have a 5.2 centimeter AAA on screening ultrasound. He wants to know how often he'll need to do follow-up imaging. Every 2 to 3 years, every 1 to 2 years, 6 to 12 months, or 3 months. Okay, excellent. So we're going to have Dr. Amy Pollock come back to the podium. Talked about hypertension earlier. Now she's going to talk to us about peripheral arterial disease. Thanks, Amy.
Thanks so much, Steve. Well, you guys still look bright-eyed and awake, so it must be a lot of caffeine. So I'm glad you're having a good day so far. Let's get started. So we're going to talk about lower extremity peripheral arterial disease. And compared to last year, we do have some new information to share. The lower extremity guidelines were revised in 2016 for the American Heart Association. So I'll integrate those new recommendations as we go through our talk. So there are 5 learning objectives: diagnosis of peripheral arterial disease, treatment of stable peripheral arterial disease, then acute limb ischemia, diagnosis and management, and then we move on to the abdominal aortic aneurysm, risk factors, screening and management, and then end with a comparison of open versus endovascular repair for AAA. So let's first look at PAD, signs and symptoms, and then the appropriate diagnostic tests. So peripheral arterial disease broadly can be thought of as either atherosclerotic or non-atherosclerotic. And we're going to focus largely on the atherosclerotic and just highlight 2 non-atherosclerotic causes. We'll look at claudication, a little bit at chronic limb ischemia, and then at acute limb ischemia. So for PAD, it's certainly very prevalent. There are estimated at least 8.5 million Americans with PAD, but it's probably just the tip of the iceberg because there are 80 million cardiovascular disease adults in the US, and PAD tends to be underdiagnosed. And we know that patients with PAD have a really high cardiovascular mortality. Even with stable claudication, their 5-year mortality is sizable, 15 to 30%. And then critical limb ischemia, a 1-year mortality is 25%. When you look at risk factors for PAD, it makes sense. Smoking and diabetes by far and away are the biggest risk factors, and then certainly hypertension and hyperlipidemia take out those top 4. When we look at non-invasive diagnosis of PAD, the ankle brachial index is really the mainstay. And you're looking at the highest ankle pressure divided by the highest brachial artery systolic pressure. And this is very testable for the boards. You have the little pop-up calculator, so it's fairly easy to do a calculation. So what you need to remember is that if you're looking at the right leg, you're going to be using whichever is higher of the 2 arms. And certainly if you have a really big difference in systolic pressures between the 2 arms and you're worried about subclavian artery stenosis, then it becomes not reliable. But assuming you don't have more than a 15 millimeter difference between the 2 arms, you actually use the higher of the 2 arms, and then for that right leg, it would be the higher of either the dorsalis pedis or the posterior tibial. So for this patient, it would be the posterior tibial at 100 millimeters of mercury, and even though it's the right leg ABI, we'll use that left arm because it's greater. So the ABI would be 100 over 140 or 0.71. So very easy, very testable, and really a free point on the boards if you know that appropriate relationship. So then what does that number mean for ABI? You get the report back. So normal for an ABI is between 1 and 1.4. As we go down our legs to our feet, there's a slightly higher systolic pressure in the ankles than in the arms. Abnormal, the number to keep in your mind for the ABI is less than 0.9. So if you get a test question with an ABI less than 0.9, that's consistent with peripheral arterial disease. There's this borderline group, that 0.91 to 0.99, where it still may be PAD, and you may need to consider some additional evaluation. And then you have the really high ABIs, 1.4 or greater. Those are the non-compressible vessels, really heavily calcified vessels. And that's where ABIs are just not reliable, and you may need to do some additional testing with ultrasound or advanced imaging. So I have 2 audience response questions built into the talk just to keep you engaged because it is 3 o'clock in the afternoon on a Saturday. So the first question, 60-year-old woman with hyperlipidemia, tobacco use, was having progressive bilateral lower extremity fatigue, discomfort with exertion. Her physical exam was pretty unremarkable. You could feel her pulses. Her ABIs fell into this borderline category, right ABI of 0.9 and a left ABI of 0.92. So what would you recommend as the next best step in her evaluation? Lower extremity angiography, you're an invasive kind of person. Repeat ABI after exercise. You don't think it's actually vascular at all. Let's do a lumbar spine MRI. Or just go ahead and write an exercise prescription because she's probably deconditioned. I'll give you a moment to cue in your answers. Ah, great. Well, you guys already are convinced about the role of the repeat ABI after exercise. Way to go. And it also tells me that you're good test takers, because the other answers really were not very compelling answers. So repeat ABI after exercise is the right answer. And she had this done, and after walking for 3 minutes, her ABIs were redone, and there was a significant fall in ABIs. And this diagnoses lower extremity PAD in the setting of the borderline resting ABIs. And she actually had bilateral iliac artery stenosis and went on to have stenting done and was feeling much better. So in terms of doing that exercise ABI for symptomatic PAD, if you have that borderline ABI, or honestly, even if it's normal and you have a really high pretest probability that they may have lower extremity PAD, have them go on the treadmill. Do the exercise ABI. Post-exercise, we're looking for a fall in ABI by 20%, or a drop in ankle pressure by more than 30 millimeters of mercury. And this post-exercise ABI allows us to diagnose really an additional 22% of people with symptomatic lower extremity PAD. You also get on the vascular lab report this pulse volume recording, so the kind of the squiggly arterial lines. For the femoral artery waveform, you should see this pretty steep upstroke, a dicrotic notch, and then this gradual fall back to baseline. In our patient's vascular lab report, her pulse volume recordings here in the red squiggly lines, you can see you lose that dicrotic notch, and it's not quite as steep of an upslope, so she has really a reduced biphasic, consistent with peripheral arterial disease. So what about patients who don't present with typical intermittent claudication, that cramp in their calf that goes away when they rest? Well, as it turns out, only 10% of people who have symptomatic PAD will complain of classic claudication. A full 50% will have some sort of atypical leg pain. You think it's arthritis or spinal stenosis or a fatigue, but it's atypical leg pain. And then 40% are not going to use any sort of pain-type words to describe their symptoms. They will have cut back on their exercise ability, and so they say, oh, I'm not having any symptoms, but when you push them, they're not doing as much as they had in the past. This idea of asymptomatic PAD is actually common in women. So this is a women's health and aging study, and it was women over the age of 65. They all had an ABI less than 0.9, so significant PAD, and 63% had no exertional symptoms that they were complaining of in terms of pain. They did have fatigue, some achiness, but no clear pain. And then this is on the total other end of the spectrum from asymptomatic, this idea of chronic critical limb ischemia. We'll spend some time talking about acute limb ischemia, but chronic critical limb ischemia is a whole other gamut, and one that I don't think will be tested significantly on the boards. But you should know that chronic limb ischemia, defined as symptoms lasting longer than 2 weeks. So acute is going to be less than 2 weeks. And rest pain, ischemic ulcers, gangrene, a high risk of amputation at 1 year. These patients really need to be revascularized to help prevent long-term tissue loss. Oftentimes for the patients with chronic limb ischemia, you lift up their foot, they get elevation pallor, they have their feet dangling on the exam table, they get dependent rubor. So that's it with the chronic limb ischemia. So we go back to more of this ABIs and lower extremity PAD. So who do you screen with an ABI? So the Heart Association guidelines gives us a fairly long list of patients who we should consider screening with ABIs. And the first two, no one's going to argue with, because it's a diagnostic test in those patients. If someone has exertional leg symptoms, you're doing it as to diagnose if they have PAD or not. If they have non-healing wounds, likewise. The controversy comes in for these other areas. So age greater than 65 to screen to look for asymptomatic underlying atherosclerosis, age 50 to 64 with risk factors, or even a younger population, less than 50, if they have diabetes and one other risk factor. And the U.S. Preventative Task Force has stated there's not sufficient evidence to recommend screening in truly asymptomatic people, so just the group south of the orange box. The caveat being that the cholesterol guidelines note that you can order an ABI in someone who's asymptomatic to screen for underlying PAD if it's going to help you stratify them into one of the clear statin benefit groups. So hopefully more to come down the road in terms of who you should be doing ABIs on for completely screening purposes. But for right now, any type of exertional leg symptoms, non-healing wounds, certainly indicated to get an ABI. What about other types of imaging for lower extremity PAD? So this is from the new guidelines, and it really kind of leveled the field between the different imaging modalities. So ultrasound, CTA, or MRA of the lower extremities can be considered to diagnose the anatomic location and severity when you're thinking about revascularization. And what I want to do is highlight some of the pros and cons of each of the imaging modalities, and certainly some centers are going to be more experienced with ultrasound or CT or MR, so there's going to be regional expertise, so know what areas your center is going to be best at. But in general, if you could choose an option, vascular ultrasound is really good when you're looking at bypass grafts. They're larger blood vessels. It's great for bypass graft surveillance. It's hard if people have aortoiliac lesions because you have the issue with the bowel gas. And then if somebody has a multi-level stenosis, you're just not able to localize very accurately the degree of stenosis. CTA. So the strengths, it's very rapid acquisition. People aren't having to stay in the scanner for a long time, like an MRI. Very high spatial resolution. You can actually tell for many patients if there's evidence of in-stent restenosis. We're limited by really heavily calcified vessels. It's just hard to sometimes tell how significant of a stenosis there is if the vessel is just lined with a wall of calcium. You get this blooming artifact and things look worse than maybe they really are. And then certainly patients need to have iodinated contrast. So this is an example of that roadmap you get with a CTA. And what I wanted to highlight was that those distal vessels are visualized really well with CTA. So then with MRA, magnetic resonance angiography, you can actually do a non-gadolinium MRA. So in people who have significant chronic kidney disease and you're worried about nephrogenic systemic fibrosis with giving them gadolinium, you can do a non-gadolinium MRA. You don't have to worry about the calcified vessels the way you do with a CAT scan, but unlike CAT scans, you can't tell about in-stent restenosis. The metal stents cause too much artifact, and then certainly if you are giving gadolinium, then you have to worry about the GFR less than 30 with the NSF risk. And then invasive angiography, certainly the strengths are very high spatial resolution. You have the option of doing intervention. Sometimes with chronic kidney disease, you can get away with a CO2 angiography. Oftentimes the images are not great. And then the limitations that we would expect, procedural risk and contrast. So moving away from the imaging to just touching briefly on those two types of non-atherosclerotic arterial disease, so Buerger's disease and Takayasu's, and this is just a moment on each, but I wasn't sure they were going to be covered in any other way, and sometimes they pop up on the boards. So Buerger's disease, typically young individuals, most of the time men with a history of tobacco use, and it tends to involve the distal vessels much more so than the proximal, and it, interestingly enough, can affect the arteries or the veins. People can even present with a superficial thrombophlebitis as well as claudication symptoms. And certainly the treatment is going to be smoking cessation, and then iloprost, one of the prostaglandin analogs, can be helpful for pain. And then Takayasu's, again, young patients, less than 40, much more so female, typically of Asian heritage, and affects the aorta and the branch vessels, so much more so of the upper extremities, but it can affect the renal arteries and lead to renovascular hypertension, and the treatment is steroids. So then let's move on to treatment of stable PAD. Certainly OMT, optimal medical therapy, this is a really similar list to what we would see for coronary artery disease in terms of lipid lowering, antihypertensive treatment, antiplatelet therapy, diabetes management, smoking cessation, and lifestyle changes. All the same things for coronary artery atherosclerosis. PAD is just otherwise systemic atherosclerosis involving the legs, so similar OMT. For statins, same idea, moderate or high intensity statin for PAD. And then in terms of ACE inhibitors, the HOPE trial from several years ago, interestingly enough, 44% of the patients had PAD, and ramipril was studied, and there was a decreased risk of MI, stroke, or cardiovascular death. So no, not everyone needs to be started on an ACE inhibitor who has PAD, but many times patients with PAD have underlying hypertension. So if we go back to the hypertension talk, when you're choosing from what antihypertensive agents to use in patients who have PAD, you could make a good argument to start an ACE inhibitor. Then antiplatelet therapy. Aspirin, we know, is indicated to prevent MI, stroke, and vascular death, reduces the odds of all of those events. The best data was from the anti-trialist collaboration. There's been variable benefit in other trials, but certainly if someone's symptomatic PAD, especially if they've had an intervention, they need to be on an aspirin. So it's a class 1 indication for symptomatic PAD, prior revascularization, or prior amputation for ischemia. And that group tends to get left out of the aspirin of the patients that I see. So remember, prior amputation for ischemia, they need to be on an aspirin, they have PAD. It's a class 2A recommendation to use aspirin if somebody is asymptomatic but has that ABI less than 0.9. And what about clopidogrel? So it's a class 2B recommendation to use clopidogrel and aspirin. And really, this comes from the Charisma trial. So if patients are at high cardiovascular risk and low bleeding risk, it's reasonable to continue them on clopidogrel and aspirin together, knowing that you're putting them at an increased risk of bleeding to help prevent thrombotic events. And then if patients have an aspirin allergy, Plavix or clopidogrel is certainly an alternative to aspirin. What about cilostazol? This is a really interesting drug because it's a phosphodiesterase 3 inhibitor. It actually helps improve walking performance in patients who have symptomatic PAD, and it's contraindicated in patients who have heart failure, and it's class 3 or 4 heart failure is the contraindication. And really, that black box warning comes as a class effect for all of these phosphodiesterase 3 inhibitors. So there are some retrospective studies based on really case series where cilostazol doesn't seem to precipitate arrhythmias or worsening of heart failure, but that has been the concern, and that's why there's the black box warning for class 3 or 4 heart failure. Otherwise, it can certainly be used. It's a class 1 indication for symptomatic PAD with claudication. You can see here in yellow, the cilostazol had improvement in maximum walking distance and then also the pain-free walking distance. And then exercise therapy this was really exciting because this is new that CMS has approved reimbursement for supervised exercise for the PAD patients. So they can have 36 sessions within 12 weeks, and folks have fought long and hard to be able to get this covered. Before we had supervised exercise therapy that's been covered, or if patients just can't commit to doing that, home-based therapy is also quite effective. This was a study that looked at, in blue, home-based therapy using a pedometer, supervised exercise in the pink or control. And they found that the home-based therapy, patients walked longer at a slower cadence compared to the supervised exercise on a treadmill, where they were walking faster for a shorter period of time, but there was a similar total exercise volume in terms of METs per minute. And both groups, home-based and supervised exercise, had a later onset of claudication and increased walking time. So they both are effective in really improving our patients' quality of life. So where does revascularization fit in for stable claudication? All of our patients should be on medical therapy. We should be counseling regarding exercise. And then revascularization is once they're on OMT, they're doing exercise, considering revascularization for stable claudication. So what's the data behind this? So a cute named trial, the CLEVER trial, looked at this exact issue. And it took a little over 100 patients who had claudication and aortoiliac disease and ABI less than 0.7, so clear PAD, and randomized them to optimal medical therapy, supervised exercise in OMT, or stent in OMT. And what they found is at 6 months, the greatest improvement in the exercise group was in their exercise walking time. But in the stent group, they actually had better walking scores and quality of life. So both the exercise and the stent group improved in terms of their functional abilities. There was now 18-month data for the CLEVER trial, and 79 patients out of that initial 111 completed the follow-up. And what they found is that if you just look at the treadmill walking time, at 18 months, it was really similar between the exercise group and the stent group, and definitely better than just doing OMT. So we don't have to feel like we need to rush into revascularizing even this group, this aortoiliac group that we otherwise kind of want to jump at revascularizing. We can take a step back, focus on OMT and exercise therapy. So when we are deciding to go for revascularization, there are 3 considerations that I like to mull over for revascularization strategies between percutaneous or surgical. First is that location matters. Inflow aortoiliac disease tends to fare better with percutaneous treatment. Outflow or infrainguinal has not quite as good of outcomes for stenting. The length of the lesion also matters. This is the TASC classification. So A, they're shorter, more focal lesions. D, they're longer levels of stenosis or multiple areas or occlusions. So that shorter, more focal disease tends to do better with stenting, and that longer, more complicated disease tends to do better with surgery, and B and C are kind of in the middle there. In terms of bypass surgery for the legs, vein grafts always perform better than synthetic grafts, particularly if you're having to bypass below the knee. So we're always wanting to try to choose a vein graft. And fundamentally, it's this risk-benefit ratio. We're looking at procedural success, long-term patency, and then wanting to reduce the risk of complication and recovery time for patient. So in many times, there's not one right answer. Should it be a stent or should it be bypass? It's really trying to individualize it to the patient. So these are their revascularization recommendations, aortoiliac. The task group doesn't feel that there have been convincing randomized controlled trials to say that open surgical or endovascular is better. The Heart Association update says class 1 for endovascular for aortoiliac disease. Femoral popliteal says typically endovascular first unless it's long and complicated lesions. And AHA says class 2A recommendation for endovascular. And then infrapopliteal, TAS said endovascular first, and Heart Association said, it's not clear benefit. It's a class 2B for percutaneous for infrapopliteal, just because the patency rates are not quite as good. So overall, vascularization with stable claudication, patients need to have lifestyle limiting symptoms. You need to have them on an exercise program and optimal medical treatment. And then if they're still having symptoms, refer for vascularization. If somebody has a really favorable risk-benefit ratio, they're on optimal medical therapy, you can go straight to vascularization without offering exercise, such as a focal aortoiliac disease. And then just briefly for that chronic limb ischemia for revascularization, it's really stratified in terms of if you have a survival less than 2 years and you don't have a vein graft, just a balloon angioplasty to help try to prevent amputation and tissue loss. If you have a survival more than 2 years estimated and you have a vein graft, then going for bypass surgery. So that takes us now into acute limb ischemia. So this drug, Vorapaxar, is an interesting drug. It's a protease-activated receptor 1 antagonist, which is certainly a mouthful, but it basically acts on the thrombin receptors on platelets. And this study looked at patients who had symptomatic PAD. They had surgical grafts in 56%, native vessel thrombosis, and stent thrombosis, and Vorapaxar decreased the risk of acute limb ischemia by a relative risk of 41%. And the guidelines say that you can consider using Vorapaxar. Essentially, it's a 2B recommendation. So what about recognizing acute limb ischemia when patients have this? It's that sudden decrease in limb perfusion, threatened limb viability, really less than 2 weeks, again, that's a differentiator, and it can be a range of symptoms. Patients can have just a crescendo change in their pattern of claudication or the development of rest pain. Those 6 Ps we learned about in medical school of pain, pulselessness, pallor, paresthesias, poikiloothermia, or paralysis. And there are a variety of causes of acute limb ischemia, from embolism related to the heart with AFib, peripheral embolism, thrombosis, dissection, and trauma. And this is an example of an embolism to the right popliteal artery on that squiggly line, Steve, and that abrupt cutoff is that acute embolism that went to the popliteal artery. So we stratified patients who have acute limb ischemia into really 3 groups. Viable, which I've color-coded in green, they have a audible arterial Doppler. Yellow, where they have plus-minus arterial Doppler as you go from salvageable to threatened, and you start to have some sensory loss, some paresthesia, some muscle weakness. This is really time is of the essence. This is the leg attack. And then as you go to non-viable, where you don't have arterial Doppler, you have profound sensory loss and paralysis. And unfortunately, only about 10% of the time do patients come in that green category, where you're really seeing them quite early. So when we look for the treatment of acute limb ischemia, unless somebody has a contraindication to being on heparin, they should be started on heparin. If they are viable or in that middle group, that yellow salvageable or threatened, they really should go for a vascularization. If they're in that threatened category, it needs to be an urgent revascularization, really within 6 hours. If they're coming in and it's that green viable, you have about a day. And if someone's coming in that irreversible category with muscle weakness and sensory loss, there's no role for a vascularization. Amputation is what needs to happen. So revascularization, typically when patients are coming in for that acute limb ischemia, symptoms less than 2 weeks, most of the time we're going for endovascular because you're able to quickly go in there, address that acute occlusion, and have a faster recovery time. You have the option of doing catheter-directed lytics, plus or minus mechanical devices, and then just having to recall the patients who you're not giving the catheter-directed lytics, recent surgery, intracranial neoplasm injury, a high bleeding risk. And then surgery, certainly you have the option of doing embolectomy, bypass, and endarterectomy. And typically that's for patients that are kind of straddling the line between acute to more of a subacute to chronic ischemia going for surgery. So this is catheter-directed thrombolysis. On the left of the screen before, you can just see that popliteal artery looks very faint gray, and then after the thrombolysis, much more of a robust vessel. So we're going to then transition away from lower extremity PAD and onto abdominal aortic aneurysm. So AAA. So an aneurysm of the abdominal aorta is anything more than 3 centimeters. And we see this in somewhere between 4 to 8% of men over the age of 60. And interestingly, most are found incidentally. And ruptured AAA is the 13th leading cause of death. So the risk factors for AAA: age, male sex, Caucasian race, smoking, family history in a first-degree relative, atherosclerosis in another territory, and then the other risk factors: hypertension, hyperlipidemia, and then the rare aortic infection. So who do we screen with ultrasound for abdominal aortic aneurysm? So certainly on physical exam, if you find an enlarged aorta on abdominal palpitation, if you find evidence of atheroemboli in the periphery, in their legs, certainly want to be screening for AAA. Or if you find peripheral aneurysm, and we'll look at popliteal arteries and their relationship with AAA, that family history, so men over the age of 60 should be screened if they've had a sibling or parent with a AAA. And then the Medicare will pay for a one-time screening ultrasound for men between the ages of 65 and 75 if they've ever smoked. And then the new guidelines, PAD guidelines, recommended that if patients have symptomatic lower extremity PAD, they should have at least a one-time screening ultrasound for abdominal aneurysm, again, because most are found incidentally. And here's an example of just all of that clot and smudge that gets in the abdominal aortic aneurysm and causes some of the peripheral emboli. So peripheral artery aneurysms, this is the popliteal. 60% of patients who have a popliteal artery aneurysm will have a AAA. Femoral has the even higher relationship. So if you do have someone with a peripheral aneurysm, definitely need to screen for a AAA. So question 2, 67-year-old man has a 4.1 centimeter AAA. Repeat ultrasound 1 year later demonstrates the AAA is now 5.2 centimeters. What's the most appropriate next step? Would you do a surveillance ultrasound in 6 months, CTA in 6 months, or refer for surgery? And in the interest of time, let's just go ahead and show the answers. Great, you guys are doing an awesome job. So you're absolutely right, referral for surgery was the right answer. So when you look at the role of surveillance, if someone has a small AAA, so less than 4 centimeters, you can do surveillance imaging every 2 to 3 years. The boards likes to test these types of questions, and you guys have done a great job with these. If it's a moderate aneurysm, 4 to 5.4 centimeters, it should be screening every 6 to 12 months. Consider beta blockers, blood pressure management. The Heart Association guidelines recommend considering 130/80 was not addressed in JNC8. Aspirin, because this is an atherosclerotic process for most patients. Statin therapy and smoking cessation. Okay, so these are the indications for surgery. The diameter more than 5.5 centimeters, 5 to 5.4 can be beneficial. It's a class 2A recommendation. Expansion of more than 1 centimeter in a year, and that's where most of you saw that that's the point I was driving with that last question. And this is interesting. For women, we're starting to get a sense that we need to be indexing their aortic diameter to their body surface area. That's not in any of the guidelines, but there's really interesting data coming out. There's a cutoff of 2.75 centimeters per meter squared that correlates with a diameter of 5.5 aneurysm for men. And so I think down the road we'll understand more so what cutoffs we should be using and if we really should be indexing for women the aneurysm diameter to the body surface area. So if someone's symptomatic, they certainly need to have their aneurysm dealt with if it's ruptured or an infectious or inflammatory etiology. So the way that I remember all of these numbers that you're getting thrown at today, and that speaks to my training, I guess, as a dancer, is sort of this jazz hands. So 5.5, I'm basically telling the aneurysm, you gotta stop. You gotta, slow down. You are 5.5. We need to stop and you need to go for surgery. So 5.5 jazz hands, that's the indication for surgery. And then the other one, I'm telling the aneurysm, I don't like that you've grown by more than 1 centimeter in a year. So 5.5, 1 centimeter per year. So that way you'll never forget it, hopefully, both for the boards and for your practice. The risk of rupture really goes up with that aneurysm size going up, and that inflection point's at 5.5, and that's where that cutoff is chosen. So in the last couple minutes, just briefly comparing the open versus endovascular repair for AAA. So for AAA patterns, we're going to be talking about the treatment of infrarenal AAAs. Once you start to get around the kidneys, the juxtarenal, there are fewer options in terms of the endovascular approach. So if we look at open surgical versus endovascular repair with a covered stent graft that goes into the aorta, one leg of the stent graft goes down one iliac artery and the other leg goes down the other iliac artery. Let's look at how we tell who is a better candidate for one versus another. The first step is you have to say, are they a good surgical candidate at all, based on their anesthetic risk and their comorbidities? If they are not a good surgical candidate at all, they're in a prohibitive risk category, then even though endovascular is less complicated of a procedure in terms of it being minimally invasive, it's of unclear benefit because their overall life expectancy is going to be otherwise significantly reduced. So we're not referring patients for endovascular repair if they are a prohibitive risk for surgery. If someone is considered a surgical candidate, then that decision between open repair and endovascular repair really hinges on a couple of things. One of them is their ability to come back for long-term surveillance, because you end up having to get imaging done shortly after surgery, sometimes at 6 months, depending upon if the post-op imaging is okay, and then at a year, and then going forward. So the EVAR trial looked at endovascular versus open repair in patients who had AAAs more than 5.5 centimeters. There's a lower procedural mortality with EVAR than with open repair, which makes sense. It's open repair versus minimally invasive. But what was interesting is that there was no difference in the long-term all-cause survival between open repair and EVAR. They both have similar all-cause survivals at 54% out at 8 years. Open repair actually has overall fewer complications when you look at the need for re-intervention because of some sort of endoleak that occurs with the endovascular repair. So when you look at the endovascular repair, it's a lower procedural mortality that does not translate into a long-term benefit. You have to have follow-up imaging pretty soon post-operatively, typically around a month. If there's anything abnormal in that imaging, they come in for 6 months, and then it's a year for everyone, and then yearly afterwards. So patients have to be willing to come back for follow-up, and there's a greater chance of some additional intervention. In terms of systemic complications from AAA repair, open repair, because it's generally anesthesia and an open surgery, tends to have more pulmonary complications. EVAR tends to have more of ischemic complications in terms of the colon, the kidneys, and then distal emboli. But as I mentioned, similar long-term cardiovascular events, actually similar renal dysfunction. The complications from EVAR, access site bleeding in 10%, and then device migration, separation of components, or limb kinking or occlusion, all of those are really pretty rare. But endoleaks is what we need to be thinking about. And an endoleak is when you've failed to completely exclude the aneurysm. And what we need to be worried about then is there a risk for aneurysm growth or rupture? And it depends upon the type of endoleak. So there are 5 types of endoleaks, and in the last couple minutes, I'm just going to tell you what I think you need to know about the 3 most important types of endoleaks. So type 1, it's the leak at the graft attachment, either proximal or distal. So I think of type 1 as being kind of a tube of the endograft. It's a problem at the top or the bottom. And that occurs in up to 10%, and that's going to need to be repaired. Type 2, you get retrograde flow from collateral arteries, from collateral vessels, and to me, the type 2 looks like the two L's in collateral, so that's how I remember that type 2 is collateral, those parallel collateral blood vessels. That also occurs in 10%, but it tends to resolve. You just need to do follow-up imaging. So type 2 endoleak is actually quite good, should resolve. And then type 3 is where you have a leak in the endograft components. And to me, the type 3, I think of leaking in between the different components. So type 3 occurs in 2%, and because it's a leak from within the components, it needs to be repaired. So type 1 and type 3 you repair. Type 2 is due to collateral blood vessels. You just follow it up with imaging. So this slide, this Kaplan-Meier survival curve, just illustrates this idea that in patients ineligible for open repair, so at too high of surgical risk, there's no clear survival benefit even if you gave them an EVAR. No intervention, total survival, or EVAR total survival, the curves were superimposed. So we've covered a lot, starting from the diagnosis of peripheral arterial disease, management of stable claudication, acute limb ischemia, AAA screening, and then AAA repair. Just a couple of board pearls. Remember the ABI calculation, highest ankle pressure and whichever brachial pressure is higher. Acute limb ischemia, symptoms over 2 weeks. AAA screening in men ages 65 to 75 with a history of tobacco use or age greater than 60 with a family history. The AAA surveillance imaging, 6 to 12 months if you have that aneurysm 4 to 5.4 centimeters, and that repair if it's more than 5.5 centimeters or more than 1 centimeter per year in growth. And then if patients can't comply with follow-up imaging, then it may be an indication to do the open repair instead of the EVAR because it's definitely more cumbersome for patients to come back for the tests. So thank you so much and good luck.
Thank you very much. All right, let's go through some of those questions again. The first one is your math question of the day. Using the information, what is the correct ABI for the right leg? Be tough. I want to see you calculate it for the left leg. Okay, we'll go with the right leg.
They're different numbers than the one I gave during the talk.
They are?
Yeah.
Okay. So as you're writing down the numbers you think are relevant, your choices are going to be 0.73, 0.76, and 0.8. And you can go to the question slide now. Excellent.
The suspense is killing me. Is this going to be greater than 95% or not? I don't know. Oh, I think that's close enough.
No. We have rigid rules. We're unbending. Yep. But a lot of you got it right. It's not bad. So there was a couple of questions about ABI. One is, do you ever just do rest ABIs or do you always order exercise ABIs, just from a practical standpoint?
Yeah, most of the time it's resting ABIs. And then it's only the exercise ABIs if somebody's in that borderline category or if I'm really have a high pretest probability that they may have lower extremity PAD and it falls into a normal category, then I'm going to want them to prove that to me and have them exercise. But most of the time it's resting.
Yeah, so the point for the one person who asked the question is, while claudication is an exercise-induced thing, their resting flow should be down too if they're going to claudicate. And only if you get a borderline thing do you have to do the exercise. If you do go to exercise, what exercise protocol do you use?
So there are two options. You can have patients walk on the treadmill, and there's actually a specific protocol for that. So it's not like the Bruce protocol where you're really trying to get them up to 10 minutes. It's less than 5 minutes of exercise. Or you can actually have them do a calf raise exercise where they stand with their hands against the wall, and they're literally going up and down on their toes.
Jazz hands?
Well, why not?
Okay. All right.
But they go up and down on their toes, and if you haven't tried to do this, it's really challenging. And so typically after a minute or two, their calves are hosed, and if they have claudication, it's brought out.
Okay, awesome. One of the other questions was, since someone claudicates and the usual recommendation is then walking for the exercise, Why do we need to document it at all? Shouldn't we just then put them on optimal medical preventative therapy and tell them to do walking like we're all supposed to do? And what's the purpose for testing in general?
Oh, in terms of even diagnosing that they have PAD?
Yeah.
It's an interesting question. So, we used to, I remember being taught in medical school that stable claudication was a pretty benign thing, that people really weren't at that much of a difference in their quality of life or their cardiovascular outcomes. But, remember, it's a systemic atherosclerosis. So these patients are at a high risk of cardiovascular events, MI, and stroke, in addition to their leg symptoms. So documenting that they actually have an atherosclerotic process, particularly if this is their index diagnosis of atherosclerosis, is really important because it changes being on an aspirin, potentially being on a statin, or if not, what their LDL lowering would be.
Okay. All right, let's go on to the next question. Question number 2 is a 75-year-old man with a history of AFib. He was not anticoagulated, presents with acute right foot discomfort over the last 3 days. On exam, he has a pale, cool right foot with inaudible Doppler sounds and at the distal pulses. He has intact strength and the following angiography. See, I got smarter. It's not quickly lines. So based on that angiography and clinical STEM, what's the most appropriate strategy for revascularization of this individual? Is it systemic lytics? Is it IV heparin for 2 days? Is it catheter-based lytics plus or minus a mechanical device, or is it surgical?
So 78%. It's kind of split the other folks between the 24 hours of heparin alone or going to surgery. So for this question, I was trying to highlight that this is acute limb ischemia. I haven't given you anything in the STEM that says that they would be contraindicated to have lytics done. And so they certainly need to be on heparin. You're going to be starting them on heparin. But because it's acute limb ischemia, they really need to be revascularized within 24 hours. And if they're that threatened category where you're starting to have sensory or muscle loss, it needs to be within 6 hours. So the 48 hours of IV heparin alone is not correct because of that timing. And then the surgery, I think the practice nowadays really is typically catheter-based treatment for acute limb ischemia because you're able to more quickly go in there, deal with the problem, get better distal blood flow, and the recovery is faster. Patients are more likely to be discharged to home than needing to recover from a more significant surgery.
Yeah. So one of the questions, there was a number of questions about the relative role of aspirin, a second antiplatelet agent. Which patients are you using aspirin for? Which ones are you adding a second platelet? Whether it's for primary prevention or after they've got a stent put in, or how do you approach that?
Yeah, so it's a really good question. So the guidelines don't give any data in terms of, or any recommendations about post-stenting, how long you should be on dual antiplatelet therapy for if you're getting a stent in your legs. And so it's a little bit of dealer's choice between the interventional radiologist. Some will use it for 1 month, some will use it for 3 months, but that's not something you're going to be tested on for the boards because it's too controversial. So patients certainly need to be on lifelong aspirin when they have PAD, with or without, if it's symptomatic PAD, with or without an intervention.
Is that 81 milligrams?
So the recommendation is somewhere between 75 milligrams to 325. And so most of the time I'm using 81 milligrams. As I mentioned briefly, the Charisma trial, there is a decrease in lower extremity events at the cost of increased bleeding. And we are faced with this decision time and time again, whether it's the heart or the legs. So if somebody is at really low bleeding risk and they felt to be at a really high risk for either thrombotic events or progression of their PAD, those are the patients I'm considering doing dual antiplatelet therapy.
Gotcha. Thank you. All right, we're going to go on to this person with an aorta on the screen. It's a 67-year-old man with a history of tobacco use and hyperlipidemia is found to have a 5.2 centimeter abdominal aortic aneurysm. He wants to know when he has to have another imaging study performed. Is it 2 to 3 years, 1 to 2 years, 6 months to 1 year, or every 3 months?
I feel good about this one.
I do too. It was on your last slide, in fact.
Oh, the suspense.
94.
Oh my gosh.
Wow.
I'm so close again.
They're getting a little
I know.
sleepy in the afternoon. Okay, just go to the next slide. There's a nice little graphic on that, I think. There you go. So for the mid-range, it's every 6 to 12
6
months.
to 12 months, yep. So
Yep.
if it's on that 4 side of that range, because 4 to 5.4 is a huge range. So if it's on the 4 side every year, once you start to get, 5, 5.1, that's the group that I'm starting to do it every 6 months.
All right, question number 4 is a 55-year-old man with diabetes, hypertension, hyperlipidemia, end-stage renal disease, presents for renal transplant evaluation and complains of neuropathy in his feet and decreased exercise ability. He has decreased dorsalis pedis pulses bilaterally. His ABIs are 0.7 bilaterally, and his CTA shows bilateral iliac artery stenoses that are significant. What do you recommend for the treatment of his symptomatic lower extremity PAD? Cilostazol, revascularization, supervised exercise, or clopidogrel? You might want to discuss that one a
Yeah,
little bit.
so this I purposely put in for kind of a more interesting question because if this patient wasn't going for a renal transplant, then I think it would really be split. You just do supervised exercise therapy, tweaking his medications, which I purposely didn't go into to let you know what could be done, or vascularization. But the reason why I decided to include it for this was just to highlight the fact that not all PAD can be thought of just in these strict silos of symptomatic exercise and OMT, and then only if not getting him better, go to vascularization, because he's going for a renal transplant is the goal. And you have to remember that the renal allograft gets sewn surgically into the external iliac artery. And so if you have a significant stenosis upstream in that common iliac artery, that you're at a higher rate of graft failure. And it's really debated now, and the guidelines may be changing for whether or not patients who are going for renal transplant should be screened with ABIs or not, because there does seem to be this higher rate of graft failure in patients who have undiagnosed and untreated PAD. So for this patient, he's going for a renal transplant, so I would send him for vascularization. He's symptomatic with this PAD, and he also needs to have good blood flow into that area where the allograft is going.
So how long would you wait after revascularizing before he's eligible for his transplant then?
Yeah, so that's a great question, and it speaks to that timing of the dual antiplatelet therapy.
Yeah.
And so it's somewhere 1 to 3 months is when you would need to wait, and then have him just go on aspirin.
Okay. And then the last question is a 80-year-old male who is a candidate for either open surgical versus endovascular repair for a 6-centimeter infrarenal AAA. Which of the following statements is true? The follow-up imaging requirements are similar for open surgical repair versus EVAR. B, only 30-day but not 4-year mortality were lower in patients who underwent EVAR. Or C, both 30-day and 4-year mortality were lower in patients who underwent EVAR. Close.
So 91%. So essentially, the thing to remember about EVAR versus open is that EVAR has that lower peri-procedural mortality, which makes sense. It's a less invasive approach to treating the AAA, but you don't have that sustained long-term benefit in mortality that more than 5-year outcomes really are equivalent between the open and the EVAR.